So now we come to the second part. So first part, I said normally these cases will be brought to clinical examination. They will be both low limb short cases, and that's what you're expected. If you got that standard of knowledge, you're likely to pass. And if you're going that scheme of conveying to examiner that you understand what you're expected, even if it is simple genovirus or simple intoing, you're not forgetting the other important causes to mention. So that's what is expected. The next one is a bit more different way of assessing the candidates for acute emergency. So we're going through septic arthritis and acute osteomyelitis, and I'm sure Apurva would have arranged, or there's already talk about, otherwise we'll do it in future, about a full talk about chronic osteomyelitis as a separate case. But today is mainly acute osteomyelitis and septic arthritis. I will touch a little bit on just general principle of managing as a complication of acute osteomyelitis, but I'll not go into detail. That we will discuss later on, as I have not discussed anything rickets today, but that we will discuss separately. Same we will discuss dysplasia separately as causing angular deformity. So the normal starting or introductory question, we will be saying that this child was just started walking 3 months ago, happily walking about a day or so, and mom noticed that he's not able to put weight at all. He is crying. He's not letting anybody touch his left leg. And only significant history is that a week ago he has some upper respiratory tract infection, which got better with simple paracetamol. No other history significant either during before birth or during birth. All injection has been given. This is the history you got. You are the candidate. You are in charge of this patient. How will you manage it? So that will be our introductory question to candidate. Just given the brief history, that so that we don't waste time in the exam. Obviously, immediately, as I said, this is a MS question, MS exam, not like MBBS exam. We want them to immediately come with top differential diagnosis, and then top diagnosis, and then differential diagnosis, and then manage whole his history, physical examination, investigation, and treatment based on that. So he will immediately, it's absolutely okay if he says that my high priority here, given the history, is that this could be a septic arthritis of the hip joint, although I'll have to take again a detailed history from patients and do a detailed examination. And I will immediately at this stage, because I quickly want his knowledge to be tested, I'll say that's all available in the history, rest is all negative. His examination, I've already told, is not letting you touch. Only thing positive in the examination in A&E today, we measured his temperature was about 102 degrees centigrade. What else you want? Obviously, he will say if his temperature is high, his attitude of the leg is in flexion external rotation abduction, which suggestive of some fluid in his joint or a psoas spasm. And with a high temperature, my suspicion of septic arthritis has increased, and I would like to confirm this by doing some further tests. So I'll tell, okay, you throw the test at me and I'll give you the result. So I would expect him to say that I would like to do a full blood count, an ESR, a CRP, a blood culture immediately for this patient. And I would say that his full blood count shows significant raised in white cell count of about 20,000, mainly polymorph nuclear. His ESR is about 70, his CRP is 60, his blood culture is awaited. This child has come to you an hour ago in A&E. He's crying, he's got temperature. What do you want to do? I would expect the candidate at this stage maybe saying that I would like an X-ray done. And I said, why do you need an X-ray? What do you expect in the X-ray? I would like him to say X-rays normally are actually normal, but we would like to rule out any trauma or any serious, very rarely some tumor condition. It is not for confirmation of the diagnosis. Very rarely I can see the increased joint space, but normally I would expect that normal, but I do need an X-ray to rule out these things. I said, okay, we got an X-ray which is normal, and this is all the test you have. This is a normal X-ray, full blood count, ESR, CRP. I told you, blood culture sent. He might say, I want ultrasound, and normally I'll throw a panel in the wheel and say that actually ultrasound is not available till tomorrow. The radiologist is not musculoskeletal radiologist. He's not confident to do ultrasound in a child. What do you do? At this stage, because we're pushing him, we want to know him the emergency situation. We would like him to say that I would like this child to take to theater. And we would ask him, what would you do by taking child to theater? Normal expectation will be that under general anesthesia, I'll aspirate his hip joint and proceed. So I will consent both for aspiration and proceed with the washout of the hip joint. And if that answer is given, we're satisfied. If we deviate that, no, I will wait for ultrasound, I will do an MRI scan or any fancy investigation, and delaying the treatment. Obviously, this candidate is dangerous and he doesn't understand the pathological destruction of the cartilage a pus can cause by waiting, and that will be bounding toward the fail. But if we go this route, that even if ultrasound not available, I will take this child to theater. Obviously, if ultrasound is available and showing a lot of fluid, then we will take this. So we will, at this stage, I would like to discuss with him that we got no ultrasound. We just on base of this history and examination, how sure you are that this child has got septic arthritis. At this stage, we would like him to quote some evidence, and we expect them at this stage to know a little bit about the Kocher's criteria, that this child actually is not walking. He was walking before, and it's not just limping, he's not walking. So that's important thing, because if child is limping, then it is not scoring. Then his ESR is more than 40. Nowadays we can include CRP, both are inflammatory markers, so they are raised. His white cell count is raised, and there is no, child is not allowing any movement. So he's got very high criteria for suspicion of septic arthritis, and because of this Kocher's criteria, which has been done, which says that if you got criteria of fever, non-weight bearing, high ESR, and white cell count, which are all positive in this case, and the chances of him having septic arthritis is very high. So even if it is not available, I would like to take this child to theater, and I would like to wash this hip joint, and that's a very good pass for a candidate to say. Even if we say that I've done hip aspiration under fluoroscopy, and sometime you can't aspirate the joint, I might throw that in as a complexity for him, and I would again expect that with that such high incidence, I would absolutely, I would like to wash this hip joint, even if I don't get, the pus may be thick, I may not win the joint, so I would like to wash this hip joint, and that's pass. And very rarely you would at this stage, which is a borderline, I would not advise this candidate that they say that we will wait for ultrasound, but no, I think there's enough criteria for him to wash this hip joint. We would like him to know